Here's the kind of the agenda for the day. We'll have a couple of lectures, and we'll try and get you up to the lab. And if there are any requests or specific things you want to see or do, then please let us know. What I'm going to do here is to review the skills that you can actually do upstairs. Some of you did this yesterday. Has everybody been through the hybrid room? Looks like a yes, huh? Not everybody's been through those endovascular skills stations, so this is kind of what you're going to do. This will save a little bit of time, because those are the three things that we want you to do, is to cross the bifurcation, catheterize the renal arteries, and then put a catheter, let's say, in the left common carotid artery. What those models are glass full-scale models that flow, actually. You can't inject dye in them, and you can't put stents in them, please, because we can never get them out if you put a stent inside these. So what it does let you do is navigate and show different types of catheters and wires that you can actually use. So let's just kind of go through a few of these basic skills. One of the reasons, the difference between a diagnostic catheter, when it's got a wire in there, you can't inject dye through it, okay? So imagine you're in a situation where you have a diagnostic catheter above a stenosis, and you manage to get a wire through it, and you want to actually check that the wire isn't through that stenosis. You can't do it because the wire jams the inside of the catheter. And so that's where sheaths really come a real advantage, actually. So for example, if you're going across an SFA stenosis, and you pass a wire up and over the bifurcation, and you get to a lesion in the mid-SFA, you really want a sheath there. So these sheaths, the ones you put in that model, are short. They're only like 7 centimeters, but they come in all sorts of length, come in 90 centimeter sheaths, even longer. And because what you want to do is to park a sheath right up above where that stenosis is. What then that allows you to do is work coaxially with a sheath, which has got a side port, which means you can inject dye, a catheter, and the catheter has a shape to it which allows you to steer a guide wire. You have a guide wire which may either be straight and can only be steered with the catheter. Remember, there's no steerability for a straight wire. Or you take an angled catheter. An angled catheter, you can basically spin it and you can advance it. Or you can take a combination of the angled catheter and the angled wire, and it gives you a lot of different combinations. It sounds like that's probably best, but it's not necessarily. It gets a little kind of complicated, and you'll learn how to individualize that. But what you want to be able to do is, if you get the wire through the stenosis or inside the stenosis, and you want to check the position of that wire, you got to take the catheter out, or you what we call upsizing the sheath. So, for example, you've got a 5 French catheter and you put in a 7 French sheath. There's a 2 French space around that catheter. So you don't have to take anything out. And so when you've gone to a lot of work to try and get across the stenosis, you can puff in dye through the sheath. And you'll hear the word puff is what you hear a lot of. Puffing a little bit of dye. It's a hand injection that's going to be given. It's through the side port of the sheath, and it lets you have some idea of where that wire and that catheter combination is. And really what you're trying to determine, is it going subintimal, or is it actually going through the center line of the stenosis where you want it to be? It's not the end of the world if you go subintimally, and a lot of the strategies actually probably depend upon it. But that's a very powerful combination. It's when you've got a sheath that you can inject dye through, which is a little bit bigger than the catheter, and a wire. That's really the platform that you're going to use for setting up a lot of these lesions. Now, there aren't any stenoses in these models upstairs. If you look at the actual electronic simulator that's up there, then there are stenoses in that. And we often talk about how do you cross a stenosis. When you look at a stenosis, whether it's on a CAT scan or whether it's on an angiogram, there's lots of things that we're looking at. We're looking at whether it's eccentric or concentric and how tortuous it is. I'll give you an example. When you're doing a carotid stent, that takeoff angle of the carotid is incredibly important. If the internal carotid is a straight shot, in other words, almost like a continuation of the carotid artery, and there's a long, narrow stenosis, you're probably going to be able to cross that pretty easily. If, on the other hand, the internal carotid comes off at a right angle, in other words, you've got to go up there, you've got to turn that wire at a right angle, and now with a right angle catheter or wire, you're trying to manipulate a wire through a stenosis, then that is a lot more complicated, and sometimes you can't actually do it. So these are the things that when we're looking at these lesions pre-procedure, we're trying to figure out just how difficult this is going to be. And one of the real challenges in the lower extremity that Tricia Roy, who was up there yesterday, is kind of working on is trying to determine the complexity of these stenoses, what is the composition of the occlusions, and trying to use that kind of imaging to drive device selection. Long way to go in this. But here's an example. Here we're coming retrograde, okay? You're coming retrograde up the right external iliac artery, and you're trying to get a wire to go through here. There is no catheter here, and so you may be lucky. The wire may enter the stenosis, and it's a combination. You don't just push this thing through it. What you're really doing is taking the wire and you're essentially rotating the wire. It's a strange combination. Everybody does it distally of a little bit of forward pressure. Everybody does it differently. It's a little bit of forward pressure and spinning the wire. The whole idea is that wire is kind of going like this, and it is gradually seeking out what the lumen is and gradually working its way through it. What you really don't want to do is jam this thing up there. It goes here, because then what happens is it tracks right up inside the wall of the aorta. And when you fluoro, and you look at this, it's going to look like the wire's inside the aorta. And the things that are clues to the fact that you've got subintimal is when you're down here and you spin a angled wire, that wire, what we call moves freely. You spin it, it moves. When it's embedded inside the wall of a blood vessel and you spin it, it doesn't move. You don't see, first of all, it doesn't reform that nice angle, and it doesn't wiggle around when you spin it. Those are the things that we look at and are clues for the fact that it ain't in the lumen, it's in the wall of the blood vessel. Now, that's not the end of the world if that happens, but you got to recognize it. Anybody have any idea how you confirm that you're actually subintimal? Anybody seen this? So typically what you're doing, again, often you've got an idea just from looking at the wire, in case you pull it back. If you're not sure, in other words, you've spent 45 minutes trying to cross this thing, and finally you got a wire, and you go, well, I'm not entirely sure that that's in the lumen. But you sure don't want to give the wire up, because you're not sure you can even get back there. What you do is you take a small catheter, 5 French diagnostic catheter, you run it up over that wire, so the catheter is now running subintimally. You pull out the wire and you hand inject. You just take a little bit of dye and you just gently puff in some dye. So what's going to happen? If you're inside the aorta, it's going to go with a flow stream. If you're in the wall of the aorta, you get this little spotted dye that sits there and it doesn't wash out, and you know you're subintimal, and that's okay. What you can't do is put a stent in subintimal space there or blow up a balloon inside that space. So recognizing it and watching how the tip of that wire moves is very important. These pictures are actually from a book that Peter Schneider wrote. It's called Basic Endovascular Skills. It's just little black and white diagrams. It's actually superb. So typically what you're going to do is you're going to try and put that wire through that stenosis on the left, but it ain't going. Then you got to make a decision about, well, what am I going to do now? Okay, you're going to inject dye. I'd probably have injected dye before this. Typically, you're going to put a sheath in the iliac system. You make a decision whether you inject retrograde. What that means is you've got a sheath in the groin, and you got to push it in pretty hard in order to get it to reflux up to the aorta. And if there's a tight stenosis, it ain't going to get in the aorta. Okay, it stops at that stenosis. You may be lucky and you may actually outline the pattern of the stenosis, but a lot of the time, you can't actually see the top end of the stenosis. Another situation that arises in if you've got an innominate stenosis. You bring a catheter and a sheath in from the arm, and you inject dye. You can see the distal end of the stenosis pretty well. But what happens is you get this, because there's a stenosis, you get this little trickle of dye comes down through that stenosis. It hits this massive aortic flow, and you can't see where the inside of the aorta is. And in order to be able to stent a lesion accurately, you got to know both sides. You need to know upstream, you need to know downstream. And so in a situation like that with an innominate, you put a separate pigtail catheter in from the groin, you park it inside the aorta, you inject them both at the same time. So you're injecting from the arm, and you're injecting inside the aorta, and that way you'll pacify both sides of the stenosis. And once you cross it, you're pretty sure how you're going to deploy that stent, because you always have to project these stents a little bit into the aorta. You can never really land them completely flush. You want to project the stent 2 to 3 millimeters into the aorta. You don't really want to stick in 1.5 centimeters into the aorta. It looks pretty bad to follow-up CAT scans, but most of this disease, a lot of this disease is aortic wall disease, so you have to be able to cross the aortic wall in order to treat it. So back to this. We've tried to put the wire across it. We can't see it. We're going to inject dye. In this case, they're injecting dye through a diagnostic catheter, and it's going to give you the outline of that stenosis. And so anybody know, let's see if Pornage is going to be suicidal again today, what imaging sequence you would use to do this? Pardon? Yeah, you're probably going to use a digital subtraction angiogram. Grab that mic and start passing it along here. So that the online audience, you had about 1,000 people watching this the first day we did, which is kind of shocking to me. So do you know what can you describe the basics of digital subtraction angiography? Because the things that you need to know about are digital subtraction angiography. Roadmap, we used to use roadmap a lot when we used portable CMs. We almost never use it. So it's digital subtraction angiography and overlay are the two things that we use.
So my understanding of digital subtraction is everything that's not moving gets taken out of the image, and the only thing that's left over is the thing that's dynamic. So the contrast that's flowing?
Basically, yeah. I mean, essentially what you do is the computer essentially looks at all the pixels in the first frame and subtracts that out of the second frame, and the difference between that frame and this frame is the fact that we've injected dye and it pacifies it. So it takes a lot of the background out of it. Now that's both good and bad. It gives you a higher resolution picture, but we use kind of bony landmarks fairly regularly. One of the things we're doing is checking off what we can see in the background. Because sometimes, you know, you're going to put a stent in, you got the whole thing marked, and how the whole machine moves, or somebody moves it, or something like that, and it's really handy. So you'll see the reps when you're doing endografts, for example, they're often drawing in the bones in the background. So it's a visual cue that something has moved, okay? And this is one of the ways you can get in trouble. You perfectly measure everything, you've got everything lined up, and all of a sudden, you look away to do something, and somebody moves the image intensifier or floats the table, and now you think that the marks that are on the screen are where you're going to mark it, and it's completely off. And so that's a way, the background landmarks can be of some value in trying to understand and what's going on. But by and large, what a digital subtraction angiogram is only going to show you the black part here. It won't show you anything else. And the way we have it set up in the hybrid room is we will take that digital subtraction study and overlay it on top of the live fluoro image. But sometimes it's too dense. One of the problems with that, gives you a nice picture, but you can't see the wire. It's so dense you can't see the wire on the catheter coming up. And so you can actually fade that down. You can control that table side by how dense it is. And people say fade it up, fade it down, okay? And sometimes you're doing it continuously. You advance the wire, fade it down, advance a little bit, bring it up, make sure it's still on the lumen. And that's the way we tend to use this. And typically the way it's set up is you have an overlay on the left screen, and we have a completely live image on the right screen. So we're not really fading it up as much. Once you get used to actually checking off left screen to right screen, a lot of people completely forget about the fact that the right screen is just a straight fluoro image. And these are things that you will learn. Okay, so digital subtraction angiography is one of the things you can do. Downside of DSA, high radiation dose, okay? That's when you're really putting out radiation. And so you don't need DSA in every case. And sometimes it's just you can actually puff fluoro in a non-subtracted image. You can actually save that sequence. Digital subtraction sequences are automatically saved into the machines. A fluoro, when you inject dye and you watch the fluoro run, non-DSA, not saved. You have to press the button to actually save that, and then you can kind of run it back, and you can use it much the same as the DSA image. Not quite as good quality, but a lot less radiation that you're putting out. And radiation safety, I know Conrad's talked, is one of the things you really need to focus on early. It just needs to be part of a lifestyle rather than something that you do occasionally. And to be honest with you, nobody's going to look out for you other than you. Everybody else is doing their own thing. Don't look to the attendings as examples of how this should be done. They're probably the worst examples that exist. You wear a radiation badge?
No.
Yeah, okay. So the OSHA mandate is that we wear radiation badges. None of us wear a radiation badge. Why don't you wear it?
Because I don't want to be restricted.
Yeah. Well, but it's not just that. I mean, to be honest with you, it's one of the dumbest. It is the guidelines, but it doesn't make a lot of sense, because what's going to happen is that they're going to come back and say, Dr. Wright, you got too much radiation a month ago. You got to do something about it. Okay, kind of it tunes you in. But I think what we're moving to, and you're starting to see more, is real-time radiation sensors. Because I want to know now that I'm getting irradiated. And there are badges you can get, the red line, if you're standing too close, and immediately, you see your name up there with a red bar coming across it, then you're going to step back. And so I think obviously has to be a combination of a couple of these things, because the national guidelines are that you got to wear a radiation badge. And radiation safety comes up and checks on that all the time. Anyway, enough about
It's
radiation.
an odd thing because it is a guideline, but they actually, it's not a law. They can't require you to do it. And the problem is if you exceed the recommended dose, which I never know exactly what it is, then they can say, well, you can't operate for a month or whatever. And it's just impractical. People just can't do it. If you're an IR guy doing vertebroplasty with CT scan guidance, you're getting a boatload of radiation. And what are they going to do, take off for 6 months and not function? So it's a challenge. The radiation thing, though, with DSA, we do way too much DSA. I would just say that up front. I think people use way too much DSA. A little bit of puffing contrast with fluoro gets you where you want to be, and we sometimes get in this habit of heavy foot DSA, and that stuff is like, what I try to do is visualize a campfire. You're sitting around a campfire, camping out, cooking marshmallows and hot dogs. Campfire's right there in front of you. If you put your hand in the middle of the campfire, it will burn the stink out of you. If you back out about 1.5 feet, you can heat your marshmallow and it won't burn you, but you can still feel the heat. You back up 6 feet and you got to be wrapped up in a blanket to stay warm. The heat drops off very rapidly. So I like to think if I see my hand on the fluoro, that's the same thing as taking my hand and sticking it into a campfire. I'm too close. If you see your hand, you shouldn't see your hands under fluoro. These guys, we do it, but it's not a good thing to do. Generally, especially at your age, you need to stay away from radiation. It's important. And backing up, again, what I try to visualize is this red hot fireball sitting there under the image detector, right, this image intensifier. And I think about it as a red hot ball, and as you back up, it drops off the radiation very dramatically. So again, you back up 6 feet, you're practically getting nothing. If you watch the radiologists, most of the time when they're doing DSA, they're out of the room with somebody remotely pushing a button. There's nothing wrong with that. And it also makes you think about, do I need DSA? Every time you use DSA, you ought to ask yourself, do I need DSA, or can I get away with just a little fluoro puff and figure out where I'm going? And I think we all need to do a better job of not abusing radiation. Wear leaded glass. Your biggest risk, numbers-wise, is cataracts. So wear leaded glass, use that shield when you can, back up whenever you have an opportunity to back away from the campfire, back away from it, and try not to get your hands in the mix. I think those are things that kind of help to guide you. And if you can use one of these, there are these audio feedback Geiger counter type things you can wear. They're very useful to get a picture of what this radiation field looks like. Part of the trouble is you can't see it. But when you've got one of these little badges on and you're stepping on fluoro and it's going tick, 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 and you back up a foot and it goes tick, 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 you get a feeling for how big this radiation ball is. And when you get up real close to it and it's just sizzling, well, again, it gives you a feeling for how tight this little ball of radiation is and how quickly you can dissipate it as you back up.
So the 3 words are time, and that's one of the things you really need to learn when you start off doing this. It's pretty hard because you're focused on learning the components of the procedure, and you may or may not be trying to run the radiation at the same time. I was thinking like Ringo Starr up there. I mean, you got your both hands and a couple of feet basically going, try to make this work. And what happens is you end up stepping on the fluoro pedal and staying on the fluoro pedal, and your attending was saying, get off the fluoro, get off the fluoro. And when we do DSA, okay, you'll see people who've been around this for a while, we say DSA, you're not usually hand injecting. Most of the time you're going to be doing this with a power injector, and that's your opportunity. You'll see everybody take a couple of steps back, except the anesthesiologists. They kind of sit there. And so they're in a very vulnerable spot. They should be behind the lead barrier, really, when they're up there. So take a couple of steps back because that distance decays exponentially. So time, distance, shielding. And the shielding you need to have wraparound lead, not these frontal lead things, because you will turn around. The scrub nurse trays over there, you turn around, radiation's still going to get your back irradiated. So you gotta have a good radiation protection, and that is essentially, you wear the glasses, you need a thyroid shield, and you need a 2-component lead, which is basically a jacket and a wraparound skirt that you're going to wear. And that's the basics of what you should be being provided with. And radiation safety's job is to come around and check the lead. The problem is that lead is enclosed within a plastic cover, so they can clean it. Well, the reason you see all these hangers for hanging lead on, don't throw your lead on the seat here. Somebody comes in and sits in the seat. The lead gets fractured, and you can't see it. So their job is supposed to come around and take all the radiation protection suits and x-ray them to see if there are any fractures inside it. So take care of your lead. Don't let anybody sit on it, hang it up, and don't just throw it in a corner. And you see that almost ubiquitously when you're walking around these rooms.
If you fold it, for instance, to travel, that's one of the worst things you can do for it. Trying to fold this leaded stuff. The plastic does just fine, but the lead inside doesn't tolerate folding very well. So it's a challenge actually for some of these reps who carry their lead with them and don't use the hospital lead because it deteriorates it pretty rapidly. That's again why they hang it. I would also, when they get ready to buy you lead and put your name on it, there's a lot of different fabric coverings you can get, and they have your favorite football team or animal print or whatever it is. I would recommend that you get the ones that are shiny, because it's a lot easier to wipe blood off of them than the ones that are like a fabric. Some of the fabrics look better, but it's hard to really clean them. And what you really want is something that you can wipe off, because you will get blood on them or other stuff. So the shiny surfaces are a little better, I think.
All right, so back to this. So crossing this lead, how would you do it, John? You got an iliac stenosis, you're coming retrograde.
Well,
we've done
personally, I use, we were talking about, his go-to catheter is a Berenstein. I usually use a Cumpy, a 40-centimeter Cumpy. I'll use a glide wire.
So let me just say, there's not a lot of difference between these two. They're simple catheters with a little angle in the end.
Yeah.
The KMP, which is what everybody refers to, probably, I think it's got a little shorter stem on it than the burn. And there can be some advantage, particularly when you're in small blood vessels. If you have a long stem on it, on the angle, then sometimes you just can't spin it as much as you want.
Yeah. I usually start retrograde. That's just me. I'll start in a common femoral. I'll take a glide wire. I work back. I hit a stenosis. If it's only a stenosis, I will almost always try to go across that with the tip of the wire. And the tip of the wires are so flexible and soft that if you can actually negotiate the lumen by the combination of spinning the wire and working the catheter, then you're transluminal as you've gone all the way across the thing. In some sense, it's easier because you don't have to leave the vessel, get subminimal, and then re-enter. Re-entry is the whole issue with common iliac occlusions. So typically with a common iliac occlusion, though, I'll try from below, take a wire, come up. Usually I embed the wire in the thrombus because the last thing that had happened in an iliac stenosis is thrombosis. It wasn't calcification. The last bit is thrombus. And that's what you're using the wire and catheter to negotiate through, is that soft stuff. And the way I was taught to do it was to embed the wire with the catheter right at the tip and literally spin that wire at 60 hertz. Just take it in your hand and just spin it. So it's got a little bit of wobble. And that wobble works its way. Somehow it finds the softest material. And next thing you know, it gets beyond the occlusion, and then you see a snake tongue. Basically, you see that curved tip wire moving. If it's moving, you know you're in a space. If you're spinning it and the wire looks like a straight line, you know you're constrained in a subminimal space. Stunningly simple, but very effective for knowing that you've crossed the lesion. Because that's your whole game, is did you cross the lesion? Are you back in the lumen? And then, of course, once you get across, advance your catheter, put a puff in, now you know you're in the lumen, boom, now you can go on with your case. The other thing we use an awful lot of is IVUS. IVUS is non-toxic. You can define the lesion very accurately. You know where you are within the lumen. It costs you something. You have to get another catheter out and use it, but it's very, very effective as a tool. Instead of using more radiation and more contrast, to use IVUS.
So,
I don't think you can
know what IVUS is. Do you know what IVUS is? Okay, everybody seen it?
IVUS is pretty handy.
Yeah, so basically it's an ultrasound chip on a catheter, gives you cross-sectional images. So you get that wire through it, and you pass the IVUS catheter, it will give you cross-sectional images looking into the wall of the blood vessel. It is ubiquitously used in dissections, variably used for occlusions. It tells you probably one of the most accurate way of knowing what the diameter of that blood vessel happens to be, and it'll tell you a little bit about the composition of it. Anything else? Excuse me. Okay, so
You know, the other thing I would say, endovascular is mostly about desire. Believe it or not, it's how much do you want this? If you're in a hurry and you got to get to clinic and you make a half-ass attempt to cross this thing, you're probably not going to be successful. There was a guy that trained years ago. He told us, never start a case thinking about what you've got to do after this case. Now, you can't always fully apply that rule, but in general, that's a pretty good rule. Once you're embedded in an operation, forget about what you got to do this afternoon. It doesn't matter that you need to be at clinic at 1 o'clock or that you've got an appointment with your lawyer at 2 o'clock. You are there. It doesn't matter what happens. There's nothing you can do outside that procedure room that's going to be beneficial to anybody. Somebody's bleeding on the floor, it doesn't really matter. You're there, you've got to focus on what you're doing, and in some ways it's very liberating because it's the one time that you can turn off all the distractions. You really shouldn't be being distracted by other things while you're doing a procedure. So endo is even more so that way, is focus. And if you really want it, you just have to bear down and keep your attention, because it's amazing how often you're doing endo, you're trying to cross an occlusion. You work, you can't make headway, but if you just stay with it, all of a sudden you get rewarded. And if you don't have that persistence, you won't manage to get it done. And I'm sure that Alan has the same experience. Somebody tried to cross a SVC occlusion, twice at an outside hospital, and they come into you and you just say, I'm going to get this done. And honestly, I really do think your commitment to the goal is as much important as what technique you use. If you want to get it, you'll get it if you stay with it.
Do you give yourself a time limit?
The time limit is mostly related to that little ticker on the screen. That's how much radiation you've used and the amount of contrast. That becomes the sort of limiting factor, because if you exceed certain parameters of time and radiation dose, which is worse when you're looking at bigger patients, the machine automatically cranks up the radiation with the bigger patient, that it doesn't take very long to start getting letters from the radiation safety people saying your patient exceeded X amount of radiation. And then you've got to bring them back to your office and check them for radiation burns of the skin and all that stuff. So you really don't want to exceed. You start getting 45 minutes of radiation, and that's you're going to start getting letters. So there's kind of a limit to what you can do, but that's again why you like not to be using DSA constantly. Fluoro doesn't accumulate the amount of radiation that you will if you do 15 DSA runs.
yeah, I'm not sure I entirely agree with it. You're in an ideal world, you're in the operation, but you're not in an ideal world. You get all sorts of pressures. Although it is liberating when you're up to your eyeballs and snakes and you've got the clinic this afternoon, and it comes a point where you realize you ain't going to make clinic and you just cancel it and you're kind of liberated. But what I always say to patients, I'm going to do what I feel comfortable doing and what I think is safe, and have that discussion with them up front. Now, there's certainly things that we do that are not safe, and it's important that the patient really understands that. Endovascular, by and large, is a lot safer than our doing open procedures. But the complications then are less expected. And so how on earth could you have a major rupture, in my case a superior vena cava recently, when you're just putting a little catheter in through the arm. And those are life-threatening complications. When people have big open surgery, you kind of expect big complications. When you're putting a little catheter in and somebody has a massive retroperitoneal hematoma, a little bit more difficult to justify, but it certainly happens. Anyway, back to the skills part of it. So what you want to do is you're going to pacify the stenosis. You're going to navigate across that stenosis with a combination of a wire and a diagnostic catheter. And once the wire goes through the stenosis, you advance the catheter through the stenosis, you pull out the wire, and what Dr. Wright was saying, you puff dye to ensure that you are in the lumen. So at that point in time, you know that the wire above and below the stenosis is in the lumen, and you're kind of golden at that point in time. Then you can deliver a balloon. If it's really, really narrow, you may have to, what we call pre-dilate, before you can actually put a stent in there, for example. because the stent is bigger and bulkier than the balloon. The balloons will almost certainly track through this. You're essentially opening up the stenosis a little bit to allow the stent to come in. And when you put a stent in something like this, I mean, we automatically are looking at this going, well, what are the challenges in stenting this? The challenge is at the distal end is we don't want to jail the internal iliac artery, which means cover the internal iliac artery with a stent. This would be very difficult in this situation because the stenosis is right on top of the internal iliac. So, but generally speaking, what you want to do is if the lesion, and you can measure this on these hybrid rooms, if the lesion is 3.5 centimeters long, then we're going to put in probably a 4 centimeter stent, maybe a little bit bigger than that sometimes. You need to overlap the proximal and distal end of the stenosis, and as you can see here, this thing runs right up to the origin of the internal iliac artery.
So let's say I just want to make sure everybody knows this one reflex. You do a balloon angioplasty of that lesion, you shoot a little retrograde arteriogram through your sheath, and you see extravasation of contrast. What do you do? What do you do? There's only one thing to do. You've just done a balloon angioplasty, you've shot confirmatory contrast, and you see extravasation. You see a little puff of smoke coming out the side of the vessel. Hemodynamically stable, no issues, but you've got a hole in the blood vessel. What do you do first? All right, how about put a covered stent in? What's the first thing you do? First, the balloon is there. So reinflate the balloon. Reinflating the balloon is the same thing as putting your finger on a hole. It's just an internal finger. The most common answer that people will give when you ask this on a board exam is they say, oh, I'd put a covered stent in. That's not the first thing you do. You stop the bleeding is the first thing. As soon as you stop the bleeding, now you can think. You can call for help. You can make sure you've got covered stents in the hospital. You can call one of your partners, you can put other IVs in, you can make sure you got blood in the blood bank, you've got all kinds of options once the balloon is inflated. So it ought to be a reflex. You see extravasation, just put the balloon back up. 50% of the time, if you just put the balloon back up and let it sit there for 60 seconds and let it come back down again, it'll tamponade the obstruction just like pulling out a 7 French sheath and holding your finger over the hole. Give it a couple of minutes and it'll tamponade itself, thrombose, put more contrast, it's not bleeding, you've got a whole different problem to deal with. Now, if you do have ongoing bleeding, then you can think about covered stents or other solutions, whatever it is. But your initial instinct should be just reinflate the balloon. So I usually, frankly, don't take the balloon off the wire on initial angioplasty. I may have to pull it out of the sheath just because you don't have enough space to inject contrast, especially with a recently dilated balloon, because it doesn't fold up to its original diameter. Or you can just pull it back far enough to get it out of the sheath, shoot your contrast, see extrav, put it back in, inflate the balloon, no problem. If you mess around and you see you've got bleeding, now you got the balloon is off the wire, your instinct, grab me a covered stent, they're running out in the back room, patient gets hypotensive, next thing you know you've got a big retroperitoneal bleed, it changes everything. So your initial response, put your finger on the hole, meaning inflate the balloon.
And the one thing you can't do is lose the wire in that situation. And so there are certain iliacs that are a little bit higher risk than others. I mean, it's pretty unusual to bust an iliac just with an angioplasty and a stent. It's not at all uncommon to bust an iliac trying to put a humongous sheath up inside the artery for either TAVR or for a stent graft. And it's very important to communicate with anesthesia. So when we're pre-dilating a iliac trying to get a 22 French sheath up, for example, we'll make sure the anesthesia attending is in the room, and we'll be telling them to keep an eye on the pressure when you take that balloon down. And you can study it very rapidly. So if you're worried about it, you take the balloon down, in this situation, you puff in dye immediately to actually look at it. And if you see that blush, John's exactly right. The second thing you do is tell the anesthesiologist, because these things, right, the patient will be stable, and 30 seconds later, they'll have a blood pressure basically of 50. These things can go badly very, very rapidly. So recognition, same as we talked about the other day, understanding what the complications are that can occur, understanding what the salvage situations actually are, and how to deal with that, when you're dealing with an emergency situation.
There's a lot, the endo stuff, there's a lot of these things that are the what do you do ifs that you can think about in advance, and you're much better prepared if the what do you do if has been thought about when you're calm and in a pre-op meeting than you're in the middle of a crisis and now's the first time you've thought about what do I do. So and there's a lot of these, like the iliac on a stick. I'm sure some of you have heard this. Is essentially what Alan's talking about. You get a sheath that's so tight in the iliac, by the time you pull it out, it takes the artery with you. This happens in radial arteries sometimes when they're doing radial catheterizations of coronaries, and you can avulse the whole shooting match. As long as you've got a wire, you've got a solution. If the wire's been pulled out, then you don't have a solution that you can do endo, because once you've avulsed a vessel, you can't get the wire back across. So your wire is always your safety net. And you will get someone who will pull a wire, we'll all pull wires out. It's much easier to pull out a lubricious wire, a hydrophilic wire is much easier to inadvertently pull out. That's why we don't typically, quote, work over a glide wire. You work over wires that are not. Now, the glide advantage is one of these hybrid wires that has a hydrophilic tip, but it's got a working body, meaning it's got a lot of strength, it's stiff, it's got a lot of corrugation on it, so it makes it very difficult to pull the thing out. And that's what you want. Once you're getting into a position where you're going to do work, then you want a wire that's less likely to be inadvertently removed. So these are all things you're going to and your attendings will all have quite specific ways, the way they like to do this, just like if you weave a basket. Everybody weaves a basket a little differently, I'm sure, and it's not a good way and a bad way to weave a basket. You just want something that'll hold your fruit when you go to market. And the same thing is true with this. You'll all have attendings that are quite precise about how they like to do these things, but you know what your problem is. What am I trying to accomplish?
So when you have a stenosis, let's say it's the SFA, which goes on to occlusion. If you have a straight tube and no branches, and you have a 1 centimeter stenosis and it occludes, that entire segment will thrombose. And it will thrombose back to the next branch. Okay, it's that ongoing antegrade flow that limits the proximal propagation of the occlusion which has occurred. And the same thing happens at the bottom end. Where the flow comes around it through another collateral and re-enters the popliteal, for example, that's where the occlusion ends. So very frequently at the top end of a stenosis or an occlusion, there are collaterals which come off, and that's where the wire tends to end up going. You put the wire down there, it's not going to straight through the occlusion for you, it tends to deflect and go down through these collaterals. And that's where you need to be able to steer that wire away. You don't have a word you'll hear again and again, it's pushability. If you're just using the wire, yeah, you can spin an angled wire, and you can spin that angled wire over, in this case, to the right side, but you don't have pushability to get it through the lesion. You need wire support. You saw the same thing when folks were actually working on that endovascular model yesterday. You gotta keep the wire straight. If there's a bow outside the patient and you push the wire, it takes the catheter outside the patient and it does that. And sometimes it actually pulls the wire backwards. So if you're looking at the tip of a wire and it starts moving in a direction that doesn't make any sense to you. So for example, you're pushing the wire in here, and remember, you're in a dark room. We do this with the lights off. It's not always that obvious what's going on top of the patient. And you're putting the wire in, advancing the wire, and on that fluoroscreen, that wire's starting to move backwards, then there's something wrong. It usually means either it's buckling up in the aorta or it's buckling on top of the patient. And so get in the habit of when you're working on top of these patients, try to keep the system straight. Okay, it's real important. And to give this pushability, you can support the wire by putting a catheter over it. And then the wire is less likely to buckle. It still can buckle, but it's less likely to buckle than if it's supported with a catheter like this. And the catheter will also give you directionality in terms of how you can actually steer that wire when it gets embedded in the stenosis. And as you work through a stenosis, the words I use are chase the wire, okay? So that when you be, let's say it's an 8 centimeter stenosis and the wire is now wiggled through 2 centimeters, get the catheter 2 centimeters into that stenosis and then we'll go through the next 2 centimeters and then follow it, so that if the wire pulls out, you're not really going from scratch when you do it. So you incrementally inchworm these devices through the stenosis if you have to. If the wire flies right through it, no problem. We kind of already talked about puff and die through. The advantage of having a long sheath, that you're working through with the tip of the sheath close to the target stenosis is you can puff dye in and let you see where you actually are and whether you're inside that stenosis and trying to cross it.
So let's say that you were in the left groin. You're doing retrograde access, left groin, you got a left common iliac stenosis. You go up and over, shoot some contrast, you get a wire over there. You could just put a balloon up. You've got a 10 centimeter sheath in the left groin. You could go up, put a balloon in, treat the right common iliac artery up and over. What's the disadvantage of that instead of putting a longer sheath in? Or what's the disadvantage of putting a longer sheath? Why would people do that? Why would you just go ahead and balloon it from a left common iliac, access, and you're ballooning, let's say, the right external iliac or the right distal common iliac? That's right. Basically, you can't see what you did. And in fact, you can't even see unless you pull the wire out. So really the advantage of using a sheath is that you can see what you did. You've got an access port that's ipsilateral to your work. Now sometimes, what's the disadvantage? You've got to upsize. You're going up from a 5 French diagnostic sheath to a 6 or a 7 French or maybe an 8 French or even bigger if you're using some of the PTFE covered devices. So that's why sometimes you'll not want to put a sheath in. But generally speaking, especially when you're starting, work with a sheath. In other words, put a sheath close to where you're working because that gives you your vision. Otherwise, you're in a dark room, you're blind, and you're feeling around trying to hope you get it right. And then what do? Balloon, then you pull your balloon back, take the wire out, inject through the balloon so you see what you did. If it looks great, it's great. But if you have a massive dissection and you can't get the wire back across, now you've kind of fouled your day up. So again, work with a sheath in general. It will make your life a lot easier because you can see what you're doing. You're paying the price of larger diameter access, essentially.
And the wire, I always think of Top Gun, with that famous line where he said, never leave your wingman. Your wingman is the wire, okay? The wire is first in and the last thing that really comes out because it really saves you if there's a problem and you got to actually control this. So Dr. Wright was talking about most stenoses, when you see an occlusion, it is a heterogeneous composition of materials that cause that, okay? What happens is that the final thing that happens, you get a high-grade stenosis, the final thing that happens is it thromboses. You don't get calcified atheroma all the way to occlusion. You get calcified atheroma to a critical lesion, and then it thromboses. And so what you're really trying to do, but you can't visualize this. Nobody visualizes occlusions. We visualize patent to patent. And we know that there's an occlusion. We know that it's a heterogeneous group of structures that are in there. But you're really trying to get the wire to go through it. And ideally, we want it to go through that last thrombosed channel. There's a lot of interest in this from an imaging standpoint. And can we actually identify where that channel is and map it out to see if we can occlude it? But that's really what you're trying to do in terms of going through this. When you cross the bifurcation in that model, you got a reversed curve catheter. Okay, on the left is simple catheter. This is the catheters we've been talking about, KMP or a burn catheter. It's a very simple catheter. It allows you to steer the wire and navigate the wire. The KMP is a little bit shorter from the tip to the angle than the burn is. It doesn't really matter which one you utilize. KMP was Cumpy, David Cumpy, the radiologist in Denver, I think is what it's named after. These other reverse curve catheters are much more complex. They've got primary curve, secondary curve, tertiary curves, and these are called reverse curve catheters. When you have a downward pointing blood vessel, sometimes it's a renal coming in from the groin, SMA always, then it's very difficult to take a catheter like this and engage, you engage the orifice, you just can't get the wire to come down in the trajectory that the superior mesenteric artery is going in. And so you can actually take sheaths that are shapeable and you can bend, or you can take one of these reverse curve catheters. The problem with a reverse curve catheter like this, Simmons, is you got to reform it. And when you're up in the head, these are the kind of catheters that are available. The one that's upstairs that you can use in that model is what's called a head hunter. And it's got one curve, two curves, and it's designed that this sits in this area here, and it drives the apex of this catheter, the tip of this catheter, along the outer wall. And when people say they navigate catheters up and over the aortic arch, they don't navigate a damn thing. What they do is it's a series of wall contacts. You use the outer wall of the aorta. When you bring a wire up here, and you'll see this perfectly in that model, and you use the outer wall of the aorta to drive a wire from here. Sometimes we curve it around in the aortic valve. And then what happens is the catheter drives up around that aortic valve. You pull the wire back and this will reform. And the whole idea is that the tip of this catheter seeks around the outer wall and pops into this. If you have a reverse curve catheter, then this curve here is sitting down inside the ascending aorta, and the tip is coming backwards, and you pull backwards. Most of the time, to engage these origins, you're actually advancing a catheter into. These, you're actually pulling it backwards, and as soon as you engage into it, you'll see that it flicks up inside the target blood vessel. The risk of stroke, okay? When you look at the inside of some of these aortic arches in the patients that were catheterized on, some of them are pretty nasty looking. And so anytime you're working up and over the aortic arch, one of the things that we're always concerned about is knocking plaque off. It's why patients get strokes from coronary interventions. Probably not from the coronary intervention per se, it's the fact they've got a bunch of guide catheters coming up and over the aortic arch. And so these are the different kind of SIMs. Whenever you see a family of catheters, 1, 2, 3, C1, 2, 3, it just relates to the diameter of that curve which you've got here. Big aortas, you want a bigger curve. Smaller aortas, smaller curve. And to reform a catheter, what you do, there's several different ways of doing this. The most common way is you take the wire and you bring it up and over the aortic arch. You bounce that wire off the valve. Sometimes you'll see it flicks right through the valve. You've got to pull it back. And then you make this curve with the wire. And then you bring the catheter. Remember, the catheter goes in straight. It comes up over here. It retroflexes against the valve. Then you pull the wire back. You rotate the catheter. That's what's going on here. And you pull backwards into the target. And if it engages the innominate and you want the left carotid, you rotate it, push it forward, to disengage it, pull it back, and re-rotate the catheter to try and get into the target vessel. So you've got to reform. The other way you can actually reform these is put a wire up into the subclavian arteries. The wire now comes out the subclavian. You advance the catheter so that that curve here is sitting right at the origin, and then you push forward. A third way you can actually do it is over the aortic bifurcation, but that's not done very often.
You will have quite specific people will have very precise feelings about how to do this. I've worked with people who would never reform a Simmons on the aortic valve. That is the idea. If you're going to reform the catheter, reform it distal to the left subclavian. So you're not doing a lot of manipulation up in the arch. Because again, if there's plaque up in the arch and you're doing a lot of this whipping around with the wire and you're not real savvy, you might as well take an egg beater and just start whipping it around. It's all going up the carotid. So I wouldn't, just be sure you know how your attendings want you to do this before you do it, because some will tell you they won't like that at all if you're up in the arch itself. Whereas where you're working, for instance, you can do it at the aortic bifurcation. You could take a wire up and over the bifurcation, form a reverse curve catheter, and then slide it up the aorta. Or using the subclavian is pretty safe because you've only put the left vert in vulnerability. But doing it across the arch is another trick entirely.
Yeah, but knowing what these are is important because they don't always work, and sometimes you need the options of how you're actually going to do this. And anyway, there's different ways of doing it. Again, catheters always go in straight. Okay, the preformed catheters, you just need to know a variety of these shapes. And the C2 catheter, which is the other one that's up in that model, you have to place the tip of them above the target, because when you pull the wire back, you put in a straight catheter, you pull the wire back, the catheter reforms and it shortens up. And so if you put the tip of it below the renal artery, then you're going to be 2 to 3 centimeters short by the time this catheter reforms. So as a general rule, start high, pull low. You can almost always pull a catheter down, but when you try to advance a catheter, sometimes it hangs up in the wall and forms a big loop. So start high, pull down, and get into the target. And what you look for, and again, you'll see this in this model, if that's the renal artery, the catheter is above, and if it pulls down and it doesn't pop, then it means you're off on the curve. You're probably either behind the origin or in front of the origin. You rotate it, and you'll see this pop. That's what you're looking for, is to see the pop when it engages the orifice. And that's a pretty good sign that you're in it. Not always. And so the next step is going to be, I think I'm in. What are you going to do now? Who's got the microphone? All right, pass it along. I think I'm in the renal artery orifice. How am I going to confirm? Put the microphone on. Is it on yet?
With
Flush a little bit. Flush with what? Heparinized
contrast?
saline?
No, contrast.
Contrast. Okay, we're going to put a little dye in there. So you hand inject, okay? You're not going to basically go to the tech, hey, hook it up, 10 for 10, powder it into that renal artery. You're right. You're going to hand inject. You don't even need DSA at this point in time because you will see, that the renal artery flushing. And so you have to take the wire out in order to do that. Okay, then you've got to put the wire back in. You do that slowly because occasionally what's going to happen is you've got it in the origin, you jam that wire up, backs the catheter right out. And so if you watch it coming up, you have the opportunity to manipulate it and make sure that wire goes out. And you need to get the wire further out into the renal artery. And typically, we always say that when you are working on a renal, you want to, and you'll go through this every time, it's optimizing the image, okay? And so if you're going to work on the renal artery, we don't care what's going on in the liver. We don't care what's going on in the pelvis. All we really need is to see that kidney. And so you want to put this in the center of the field. The way we typically do it is have the target, which is the stenosis, in the middle of the field. That means the aorta for the left kidney is a little bit to the left. You want to see the outer wall of the renal cortex on that field, okay? You don't want to jam a wire through the renal cortex. And that's another complication that you'll see, particularly with glide wires. So what we use is the glide wire to steer us to get to the position that we want to be in. Once we've done that, so I would re-engage the catheter sitting at the origin, put the glide wire back up there, advance the glide wire across the stenosis, put it out in the hilum of the kidney, advance your catheter over that, and then change out for a stiffer wire. Typically, we use a thing called a Rosen wire. A Rosen wire is a stiffer wire because it's got a little tight J on the end of it, so you're not going to jam that out through the renal cortex, and it will give you the support to now take the catheter out, take the short sheath out of the groin, if that's what I've got, and then advance typically a 35, 45 centimeter sheath up into the origin of the renal artery. Because the way you're going to set this up is you're going to have the sheath right at the origin of the renal. Now we've got a wire going across the stenosis, and you can deliver a stent up and into that stenosis. You've got to make a decision whether you're going to predilate the lesion or not, or whether the stent will actually cross on its own without predilating it. And if you get in trouble with the stent, for example, so sometimes what happens, you try to put the stent across the lesion, and it starts backing the sheath back. Not at all uncommon for something like that to happen. Take the stent out, predilate it. Or the stent starts displacing for whatever reason. Having a sheath there is also a big safety mechanism. Gives you a lot more options than if the sheath's way short of the origin of this. So this is one of the things you can try and do really when you're upstairs. And then last thing you're going to do in that model is cross the aortic bifurcation. How do you do it?
Well, I use an omni flush mostly. I hardly ever use a pigtail because I'm not sure there's a real advantage to it. Basically, the concept of the pigtail or the omni flush is you got a shape at the end that's kind of keeping the catheter off the wall. So the omni flush works just as well. That's basically the little shepherd's hook with multiple side holes. It's convenient because then you've already got a reverse curve catheter in place to catheterize the opposite side. So what I try to do is you don't actually have to point the shepherd's hook towards the opposite wall. Sometimes you can have the shepherd's hook pointing towards your ipsilateral access side, and the wire will kind of bounce off the ipsilateral wall of the aorta and get into the proximal common iliac. Once I've got a few centimeters of wire into the contralateral common iliac, then you pull your catheter, your reverse curve catheter and wire together down. So you pull toward yourself, and as you do, you engage that shepherd's hook right on the bifurcation. And once it's hanging on the bifurcation, now you have a kind of a stable catheter that you can then advance your wire down into the groin. Because what you're trying to do is get that catheter typically down into the common femoral. To get it to follow that wire, you need some, quote, purchase, meaning you need to have your wire down into the profunda or into the SFA, depending on what vessel's open. If you try to get your pigtail or your omni flush to follow a wire and you're only down barely into the common iliac, it won't follow that curve. It'll go up into the aorta. You need a little bit of drag. In other words, you need some purchase of your wire up and over for your catheter to then chase it.
And that's a tricky thing to do. And there's also, and you won't pick it up today, it's hardly even worth going into, but when you do that maneuver of pulling the catheter down with the wire so that it engages the aortic bifurcation, if you've got significant disease in the iliac, where your wire is not able to further advance, you have to kind of do a little bit of a fancy move where you're slightly withdrawing the wire as you pull the catheter down, and to prevent the catheter from being pushed up into the aorta. That's a little bit hard to explain, but it is a fundamental thing that you will learn how to do. So while you're pulling the catheter down, you're also withdrawing the wire, because if it's hitting obstruction downstream, it's going to flip your catheter out. Is that too?
No, that's good. Because you have to do that upstairs. So what happens is that you got to reform the catheter, and they saw so many, we do exactly the same thing. Unlike the Simmons catheter, which I showed you, the thing is that long, so it reforms. It's too big for the diameter of the aorta, so that when you pull the wire out, it kind of goes like that, and it does not reform into a shepherd's crook type pattern. The Sos Omni will. It's got a much tighter curve. So you pull the wire back, and the catheter will automatically do that. And then you're coming through this with the wire, and you're kind of pointing the wire down here. And so sometimes the wire will go back down the same side as you went up. Sometimes it goes down the opposite side. Sometimes it kind of wraps around this and goes down the opposite side. Then you got to figure out how you unwrap it in order to be able to do that. So when you get a wire down like that, now it's not down very far is the problem. When you push that wire, it pushes the catheter up. And so what Dr. Wright was talking about is engaging the bifurcation. Again, these are words that we're so used to using, I really have no idea if you know what we're talking about some of the time. And so what it is you want that catheter to be sitting right there, okay? And if you leave the wire here and pull the catheter, then the whole thing basically will come out. So what he's talking about is what you do, we say, the words we use are shorten the wire. So you've kind of got a hold of the back of the wire at the same time, and you're pulling the wire down at the same time as the catheter is coming down here. And so what I typically want to see when you set this on the bifurcation is I kind of overdo it to start with. The red is the catheter. So the catheter will be sitting down like this. You'll pull it back, and as you do that, the tip will come like that. Well, it will become, the catheter will go like that. We know we're set on the bifurcation at that point, and then you push the thing back in a little bit. And at that point in time, you know this is sitting right like that, and it gives you a lot of pushability. And now you can advance that wire down the other side. You get to practice, because those glass models are remarkable.
It's hard to explain, honestly. What you're essentially doing when you're, quote, shortening the wire is you're leaving the wire tip in exactly the same location. The wire tip, if you keep it in the same spot and you pull the catheter down, well, it would advance, right? So you're having to withdraw the wire as you pull the catheter down to keep the wire tip in the same location. That's the trick part of it. And then once it's down, then your issue is whether you go down the hypogastric or whether you're down the external iliac. And, you know, we have a tendency in Dallas, for some reason, they like to use Bensons for this. I don't like using a Benson because it's a non-directional wire. And if it goes down the hypogastric 3 times in a row, it's probably going to go down 4 and 5 times. Yeah. So one of the things that I'm sure your attendings will say to you is, do something different. They're sitting in the back room watching this fluoroscopic adventure, and you just keep repeating the same little failure. Don't do that. Try something different. Just change shapes, move something, get a different wire, get a different catheter, do something, but don't just keep repeating the same thing over and over. There are lots of different ways to solve it.
So what happens is you come in here with the wire, and the wire goes like that, okay? Yeah. And you'll bring it back and try to spin the wire and see if you can spin it off. And the other thing you can do is by pulling down on your catheter. As you pull down on the catheter from the right groin, it does that with a catheter, which means it projects the wire in a different direction. And sometimes that's enough to kind of get you out of it, okay? And what I will say is keep putting the wire in. Get as much wire in as you can. While you're doing that, you're looking at that catheter, okay? You want to have the whole thing in the field. You want to see where the tip of the wire is. But if all of a sudden the tip of the wire hits something, it's going to start backing that catheter back. And that's when you want it to stop. And there's different ways of try and exchange.
It's the concept of one-to-one movement. If you're pushing a wire on the back end, you've pushed it in 2 inches and the tip didn't move 2 inches, well, that 2 inches got taken up somewhere. And it's particularly true when you're working on a popliteal or a tibial and your bifurcation is not in the picture. And you're down here pushing away and nothing's moving, well, that's because your sheath is getting pushed up into the aorta. You're accommodating that length somewhere else in the system.
So one of the things that I noticed, I'm going to try and get this up in the lab. Actually, I'm talking to Becca, see if we've got them up there, is the use of a Fogarty catheter. We probably need to incorporate exposing the Fogarty catheters in this course. This is probably the single most effective way of moving clot that's ever been invented. And it's worthwhile telling Fogarty. So he stood at this podium probably a year and a half ago. And Fogarty, when he was before he even went to medical school, was working as an OR orderly. And at that time, he helped the surgeon. And what they did was they opened the artery in the groin and they reached up with metal instruments and tried to pull thrombus out of the iliac. It didn't work very well. And so what he did was he was a fisherman, by the way, and he used to tie his own flies. And so what he did was he took the tip of a surgical glove, put it on the end of a catheter, tied it on basically with fly tying techniques, put a little syringe on the end, went at this guy and said, hey, what do you think of this? Syringe up here, blows up there. Oh, that's a great idea. Much kind of like the DeBakey who said, we went to the IRB was me. I said yes, so we went ahead and did it. And that was the whole genesis for the development basically of a Fogarty catheter. And it is something you will use 3 or 4 times a week, particularly if you're doing dialysis access. This is one of the main ways in which clot is actually being removed from devices, I should say. And there are over-the-wire Fogartys, which are essentially using endovascular techniques, and sometimes we use them intraoperatively, and you pass the catheter beyond the thrombus, you blow up the balloon, and you essentially pull it back. And what you're looking for is, we're always looking for what we call the plug. So anybody know what's going on here? What you're looking at, so this is just nasty old clot. This has been static clot that's formed. Here is when you see a polished surface like this, it's because there's flowing blood going across it. That usually tells you. So if we're going retrograde up into the iliac artery, for example, this is the bottom of the aorta. The contralateral iliac would be here. The aortic flow would be coming down here. It polishes the surface of that thrombus. And so we really like it when we pull this thing out and go, oh, there's the plug. That means you got what you really got, you came to get out of it, and usually means you've got pretty good flow. You got to do an arteriogram to confirm it, but that's essentially what it means.
Many people use the term meniscus for that. So you're looking at that hollowed out surface where there's flow. You see that, you know you've gotten to the end of the thrombus. That's you don't have to make a lot more passes. Fogarty is a great device. It's also that's the animal model for intimal hyperplasia, is to take a balloon and rub it inside a blood vessel and damage the endothelium. So it's inherently a damaging process to take a balloon, inflate it, and rub it up and down the endothelium. So you want to do it as few times as possible with the least amount of pressure required to get the job done, but you also want to get the job done. And that balance of how hard you inflate it and how much you pull is why it's a 5-year program. That's something your brain is going to calibrate. And there's really no trick to it. It's all about sort of adjusting your brain to how much force, and you're essentially trying to feel the contours of the inside of the blood vessel with your fingers. And it's not a simple thing to do. I mean, actually, I ruptured a radial artery the other day on a thrombectomy of a dialysis access out in the mid-forearm, just because I was too aggressive with a balloon. Do you use saline or air in a Fogarty, by the way?
Saline.
Except for what? A 2. If you put saline in a number 2 Fogarty, it won't come back out. The capillary tube is too small to accommodate it. So when you're doing little tiny blood vessels, it'll even say on the Fogarty, don't put saline in this thing, because you'll get it in, the balloon will come up, and it'll just stay there. So for the very small, I use air actually for all of them, and there are arguments why you shouldn't, because it actually increases wall shear. But I find that it responds quicker, that air goes in and out quicker, so I can sort of feel the vessel better. People who use saline like saline because it's more viscous, obviously. It doesn't compress, so there's less variability in the syringe.
All right, pass it along. Linda Lay is doing an emergency TVOD at the moment, so we're going to cover a few vascular emergencies. Okay, my friend, you're up. What do you see? First one.
So starting there on the left,
Yep.
so just on gross examination of the feet, like immediately apparent is that the patient's left foot is a different color. There's a bit of pallor in that left foot. There's a wound under the left great toe. Also, arguably another wound on the second toe on the right. Seems like there's also a bit of callus. There's some stripping under there on the right foot as well. And a bit of deformity potentially there on that right.
All right, left foot hurts like the devil.
I'm sorry?
Left foot hurts like the devil. Sudden onset, severe pain about 4 hours ago. Right side's normal.
Right
It's the
side's
normal side, okay?
So in that case, I'm thinking maybe an acute, okay, this is a cold leg, potentially. You have some kind of occlusion going on.
Acute ischemia. No previous history.
No previous history.
Was doing great yesterday. Got palpable pulses in the right foot.
Palpable pulses on the right. And on the left?
Left, no pulses below the femoral. Got a femoral and no popliteal, nothing distal.
Okay, so in that case, then I'm definitely thinking that this patient occluded and will potentially need, well, will definitely be going to the OR for like a thrombectomy of some sort.
Okay, well, let's stepwise get to what we're going to do. Okay, so you think the patient's got an acutely ischemic leg. I completely agree. You're going to call the attending. He wants to know about his compartments.
Well, so we'll be doing compartment pressures.
Okay, I'll just examine them first. So you're going to examine the calf. You're going to squeeze the calf. Patient starts yelling at you. You know, that's not good. If the patient basically, it's soft. And what's the most commonly affected compartment?
I believe it's the no?
Anterior.
Anterior.
What are the
Yeah,
compartments?
what are
Let's
the-
start with that.
I believe it's the
I got a
anterior
slide on
compartment.
that too, but we'll cover it now. Go ahead. Yeah. All right,
there another
fair
question?
enough.
Sorry.
Let's go through them. Well, we'll come back to that. Okay, I got a slide which will show you what those compartments are. Okay, so what we want to know is, can the patient move the foot? Do they have motor function? Do they not have motor function? What is the sensation intact? And really, does the calf hurt when you squeeze it? And the anterior compartment hurt when you squeeze it? And no, that is good. And then we've got to figure out what we're going to do about this. You think, based upon this history, this patient probably had an embolus, okay? Emboli are good. We can usually fix that fairly rapidly. In situ thrombosis, usually bad, but they've usually got a previous history which gives you some idea of what's actually going on in this patient. Okay, so where's the blockage?
You said there was no pulses below the femoral?
Yep.
So most likely probably in the SFA would be
So
my
probably
guess.
SFA or popliteal.
Or popliteal.
Typically, emboli, you usually think of them as lodging at branch points, where a blood vessel goes from bigger to smaller. All of a sudden, the big embolus comes in and it kind of hangs up based upon its diameter, is generally what we think about. Or they got a pre-existing stenosis and it hangs up inside the stenosis, for example. Okay, so what are the options? You're going to call Dr. Wright. He's on call. He's mad. It's 2 o'clock in the morning.
I don't take call. You're not going to call me. I guarantee that. Hey, what do you, while you're thinking about that, what do you think about that right foot? First of all, how do you know it's the same patient? I mean, you don't really. They are awfully different looking feet. It's a funny looking thing, really. But what is that right foot? To me, what happened on that right foot, you see that scaly skin that's kind of rehealing? You sometimes see that when somebody's been revascularized about 3 weeks ago. And it makes me think somebody had something happen in that right foot that was previously ischemic. Now they've got a kind of reperfused foot that's healing and the snake skin is sort of shedding. So they've had some kind of procedure on that side. Now you've got something's happened to the opposite leg 3 weeks later. And I'm not sure what exactly the story was, but the little ulcer on the tip suggests to me that there was a revascularization procedure on that side, and that's why they've got a pulse over there. This side is not good. And it could be in situ thrombosis, because again, nature loves symmetry. It's uncommon to see people who've had no disease in one leg and atherosclerotic disease in the other. That's more likely embolic. Whereas if I know something has happened on that other leg, then I'm worried more that this may be in situ thrombosis. But just as that little interlude, now I've given you time to think about what you're going to do.
Well, in this case, I'd be thinking about doing an embolectomy, potentially, depending on, you said the calf compartment was fine, so maybe not so much a fasciotomy. I guess we could figure out once we get in there.
So acutely, it's pretty uncommon with acute limb ischemia to have a compartment syndrome, meaning the pressures are not going to be high in the compartment because there's no perfusion. You can have tenderness, which is a pretty important thing. We do that quite a bit. And in fact, I think that our residents miss that quite often. We'll say, is the calf tender? If you walk up to somebody with an acute limb ischemia and you kind of squeeze the calf and you feel they've got tender muscle, that's a whole different animal. They're not typically going to have a compartment syndrome, because there's nothing perfusing it to cause it to be. But if they're tender, that's somebody that when you do reperfuse them, you got to really think about, that's somebody that's going to get a compartment syndrome if I don't do a fasciotomy. So it's a pretty important part of the physical exam, to sort of check that calf tenderness to see how tight it is. So before you did a thrombectomy, though, is there anything else you could do in advance? Anybody? Well, you could heparinize them. Yeah, you probably would heparinize them unless they had a brain tumor. You're pretty much going to acutely heparinize virtually everybody you suspect of having acute limb ischemia. You're very rarely going to get criticized for that. I mean, that's the standard of care, is immediate heparinization. Anything you can do diagnostically. Do what? You can always do an angio. Now, that becomes a bifurcation point again. Your attendings are going to have quite specific feelings about this. Some are going to say, shoot some contrast in this leg, figure out what you're doing. Others are going to say, go straight to the operating room and do a thrombectomy. Some are going to say, go get TPA and do it. But in other words, those are, again, what's the problem? The problem is acute limb ischemia. How you solve that problem, that's what you're going to learn over the next 5 years.
Yeah, I mean, the other thing to do is ultrasound. I'm frankly always amazed how facile our residents are. Where they go, oh, well, I just took the scanner up there and I scanned them, and there's thrombus going up and down the SFA. Ooh, not sure I'd even thought about doing that, quite honestly. Okay, so the patient's got an acutely ischemic leg. They've got an embolus, which is hanging up above the popliteal artery. You have multiple options in terms of what you're going to do. By and large, if it's clearly an embolus, I'm probably just going to operate on them and do a Fogarty thrombectomy. If it's inside thrombosis, you're going to lean more on the line basically of doing lysis to try and reveal what is the underlying problem is, that you can go ahead and stent it. It's a little more challenging to run a Fogarty catheter through long stenosis in an SFA, and you may well not be able to do it. But that's kind of beyond the scope of this today. These are the options of what you can actually do. Okay, hand it back to Dylan. Middle patient. There's another emergency. Patient comes in. 2-day history, swollen left leg.
Sure, so this looks like a female with left leg swelling, the entire leg, all the way up to the groin. In 2 days, so I'd like to know if she's in pain, if she's been
Whole
walking.
leg hurts.
Yeah. And I'd like to know if this happened before, or she's been traveling.
Yeah, okay, so you're thinking it's what?
A DVT.
Okay, so ultrasound shows that she's got an iliofemoral DVT. What you going to do?
Check her COVID status. I mean, seriously, this is COVID leg, right? This is something we didn't see very much, but these people that have acute thrombus that walk in the door in this era, COVID is very part of this whole workup right now that it wasn't, 2 years ago.
Well, she needs to be started on heparin. I believe we stop propagating this clot, and then we could start with elevation. I don't think it's necessarily does she still have motor and sensory function in her leg?
All intact. So
Yeah.
you're right. You've got an iliofemoral DVT confirmed with ultrasound. Sometimes we'll get a CTV, depending on what we're considering doing, and that's largely to tell you the proximal extent of that thrombus is. Put an inferior vena cava filter in.
What was the question? Do we want
Put an
to?
IVC filter. The CT scan shows that there's clot hanging out of the left iliac vein up into the inferior vena cava. The answer is no.
No, I don't.
No indication to do that at this point in time. And again, we're not going to go into all the different ways you can treat this. If it's an elderly patient, you're probably just going to anticoagulate the patient. If it's a young patient like this, we're at least going to talk about mechanical thrombectomy. A lot more mechanical thrombectomy being done, than before. Okay, good enough. Okay, next one. All right. This is a patient who Dr. Wright basically did an iliac stent on, a right iliac stent on, retrograde, yesterday.
Okay, so we can see on her right groin there's a hematoma and swelling and edema significantly greater on the right where the access was compared to the left.
Thigh hurts, legs otherwise okay. Not too happy that it's twice the size of the other one, but
Right. We'd want to check to make sure she has pulses in her
yeah,
femoral.
she's got pulses.
Okay. So most likely the hematoma, we'd want to check to see if it's growing, if it's pulsatile.
Yeah, so probably get an ultrasound, make sure there's no pseudoaneurysm, something like that in there. Check the hemoglobin, check the coags, and if there's no pseudoaneurysm, what are you going to do? Here's what it describes: is there's no focal hematoma that they can identify. There's diffuse hematoma, but nothing, no big clot that's sitting in there.
Yeah, as long as there's no sign of infection, we wouldn't need to debride or
Probably going to
evacuate.
wait. Okay.
Yeah.
If there's a big giant hematoma, if you describe a 7 or 8 centimeter hematoma in there, probably going to. I hate evacuating these things because they always get infected. To be honest with you.
How do you know this is not a retroperitoneal hematoma?
Does the patient have back pain?
No,
or
there's a
no?
plain of her thigh.
Okay. The blood probably would have been more hidden if it had been collected only in the retroperitoneum.
Could it be simultaneous?
True.
Pretty uncommon. Generally speaking, where the inguinal ligament comes down on the femoral sheath, that's a pretty significant barrier. And if you've got blood in the thigh, it's very uncommon to have a true retroperitoneal bleed unless they had 2 ice picks in the groin, which sometimes happens. You could have multiple access sites and you could be bleeding retroperitoneal. But typically, if you've got a single access site in the common femoral artery, if that bleeds, it's either going to bleed below the inguinal ligament or it's going to bleed above because you had a high stick. You typically, if you see thigh bleeding, it's usually safe. Whereas if you have somebody that's got, right iliac fossa pain, and they've had an angiogram, and you're not sure, that's the person you get a CT and make sure they haven't gotten a retroperitoneal hematoma, because it's hard to tell. If their problem is mostly in the thigh, usually that means that your stick is below the inguinal ligament, and all you're dealing with, you don't have to worry about a sort of 2 o'clock in the morning death because of an undetected retroperitoneal hematoma. That's that's the classic intern failure. Got called to evaluate a groin, kind of went and saw it, said there wasn't a big hematoma, there's a little bruise, and 3 hours later they arrest, they've got a retroperitoneal hematoma. That's one you probably want to avoid. You don't want to just kind of ignore that one. Bleeding in the thigh, nobody dies from. Bleeding in the retroperitoneum, they die from it. So you want to have a lower threshold for getting cross-sectional imaging, or better yet, kick that one to a senior resident and said, hey, I'm not sure, there might be a retroperitoneal hematoma, there might not be. That's one you don't want to take on the chin the first year. CT scans is the easiest thing. Do you need contrast? No. All these people have a creatinine of 2.1 because you did it for diabetes, and you don't need more contrast. So just a non-contrast CT, you're not looking for super thin slices. All you're looking for is hemodynamically significant hematoma, which means you can see it on just non-contrast CT. Takes not very long in most hospitals to get an urgent CT with a few slices done. It's all you got to have. You see it, makes a much different plan. Now, what are we going to do? You make sure you got IVs, you make sure you got blood bank. You may not have to do anything, but you're much more better prepared than you would be if you just kind of blow it off and say, well, it's a groin hematoma.
So retroperitoneal hematoma is a fascinating subject, actually. It's terrifying in some respects. There are spontaneous retroperitoneal hematomas just because the patient's been anticoagulated. Why that happens, beyond me. Generally, we're not operating in those patients. Generally, it's fix the anticoagulation. You can never find where this is coming from. By the time you get in there and evacuate this big thing, there's just more bleeding things that you've created. It's very different when there's been a puncture. There's something to fix. And that's the time that you want to operate in those patients. But guide wires can go anywhere. And so I've seen patients who, groin puncture, belly pain, they got a lump. This lump is right here. What they've got is a rectus sheath hematoma. How do you get a rectus sheath hematoma from a groin puncture? Because the wire probably went up the inferior epigastric artery and ruptured it. And so wires can go anywhere. As a general rule, if something's going wrong with the patient in PACU, it's because of what you did until proven otherwise, and just backtrack through the operation. And if you get called and you don't know what's going on, you always want to talk to the person who did the operation. So we cover for one another on the weekend. You know, if you're going to take one of my patients back, or I'm going to take somebody else, you always call that attending. What happened? Because a lot of the time, oh, Lord, man, X happened, and I didn't think it was going to be a problem. That's usually where the problem is arising from. So you want to know what the sequence of the operation was, and potentially things that may direct you towards what the complications.
Believe it or not, there's science behind that. There was actually a study done at looking at predicting postoperative complications. And you do a whole multivariate analysis, age, gender, what the operation was, blah, 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 all this stuff. The most accurate predictor is surgeon gestalt at the end of the case. People have a feeling for what the bumps in the road may be coming up. And talking to the person that was there is absolutely very, very valuable. Oh yeah, you know, we did have a little trouble getting the sheath in, or I had to pull the wire back out and I put it back in, and whatever it is, that surgeon gestalt thing is very, and it's true of open surgery as well. So It's a really important point.
Okay, so pass it back. Okay, the right side. This is a patient that had an aorta bifem 2 weeks ago, comes back to the office, and the groin looks like that.
Does not look good.
Does not look good.
If I was describing what I'm seeing, there's some erythema around the incision site near the groin. I would probably want to kind of see how tender there is,
Squeeze
if there's
it.
any purulence
All
coming
this
out.
old stuff comes out.
So I'd be very, very worried about an infection, and since there's a graft in there, I'd be worried about it seeding into our graft.
So antibiotics and send them home?
No.
No, probably not. Okay. I mean, infection with vascular grafts, not good news in general. Across the board, it's just not good news. If it's a vein graft that happened to be in there, then you worry about these things blowing out. If it's an artificial graft, the graft's not going to blow out. The anastomosis may actually come apart, but all of them need to be admitted. Probably going to get a CAT scan to look at the entire rest of the graft, make sure the other groin's okay, and then figure out what you're going to do. We're not going to go into figuring out what you're going to do at this particular point in time, but if you see this, patient needs to be admitted, even if it's a dialysis access graft and they've got draining pus or anything like that in relation to an artificial graft, bring them in the hospital. Okay,
Yeah,
next.
We kind of went over that the other day, but it's probably worth re-emphasizing. The patient on the left, they call you at 2 in the morning, pulsatile bleeding from the groin. What do? You do put on a glove, you know, or two, and you put pressure on the wound. And you don't take pressure off until you're in an operating room and a surgeon who's gowned and gloved takes over and puts pressure on. You walk them down the hall, you take them down the elevator, you get to the operating room, you just keep holding pressure. That person will survive 100% of the time. You start monkeying around and you let pressure off and you try to put a C-clamp, or you get somebody else to do it, or you hope it holds, or all of that stuff, forget about it. Just hold pressure. You don't have to get a bunch of rags. You don't have to put a bunch of pile on. Single pressure with one hand, stay there until it's fixed. Everybody survives. But and you will see this, I guarantee you will see it. It means you can't go to the EMR. Somebody else has got to come. That's why you put one glove so you got one hand on your phone. Call for help. And somebody else gets to go do the EMR, somebody else gets to call the OR, somebody else gets to call the attending. You hold pressure, that's your number one job. You get that done. If somebody else can put IVs in, somebody else calls the blood bank, your goal is to hold pressure. Somebody's just stay there, hold pressure till you're in the OR. Safety, no problem.
Okay, who's next? This is a femoral AV loop graft in a patient's thigh. So what you're looking at here is one of the access sites that's kind of breaking down and got this crust over it. And you got another one here that's got a big ass hole in it.
I guess what I see is there is, on the medial aspect of the thigh, there is a...
What are they doing? Yeah. What is that person just torturing the patient just a little bit more, or what are they actually
I
trying
think
to do? here?
they're trying to hold pressure so that it
Pardon?
doesn't... Holding pressure.
Well, I mean, they're holding some kind of pressure. They're actually trying to thrombose. They're actually trying to occlude the graft. So they're trying to feel where the graft is, and that's not that easy to do, to be completely honest with you. So they're trying to control any bleeding that's coming out of that by pinching the graft. The two loops come together up in the groin. Typically, the inflow is obviously usually lateral because that's what the arterial side of it is. What they're doing is grabbing that inflow of the graft and trying to pinch this thing closed. And they're going to go to the operating room. And you're going to prep around that hand, just as John said, and then the surgeon's going to get scrubbed. They're going to quickly release that, prep that little part. Somebody else is going to grab it, and then they're going to cut down, probably get inflow control of that before you actually deal with cutting down and excising that big eroded aneurysm that you've got down there. It's truly amazing the size of the aneurysms that you sometimes see on these access grafts and fistula. And why they don't erode more than they do, I really don't understand. But this is a pretty common scenario for us to see this, and it's not easy to fix it, actually. Everybody poo-poos dialysis access. It's a big deal, and some big operations associated with it. Yeah?
My instinct, if I saw this, would be to try to put pressure over the bleeding itself. Is the right answer just to try?
No, I mean, that thing is so big, I suspect that they tried to do that and it may be bleed because it's so big and so necrotic. That's one of these situations that may be difficult to apply direct pressure on. So you do whatever it takes. If you can put direct pressure on it, it's probably the best thing to do. If you put direct pressure on it and it's still bleeding around it, then you can try
It's
and
kind of the point,
grab that graft.
Dr. Peden made the point the other day, almost everything can be stopped with one finger. That's almost. And if you got a hole bigger than one finger, then you got a big problem. If you couldn't squeeze this graft, what could you do to keep him from bleeding to death? Put a pneumatic tourniquet on.
Put a tourniquet on.
Right? Just put a blood pressure cuff on and pump it up. You may sacrifice the limb, but you're going to stop the bleeding. And it's unlikely that you'd actually lose the limb because you got several hours of total ischemia with a tourniquet that you'd tolerate, right? The orthopedic guys do it all the time for total knees. So it's not as though a tourniquet's going to be a limb-threatening thing, unless you were putting them on a helicopter and flying them someplace. So don't forget, tourniquets on extremities will stop bleeding. Can't use tourniquets generally on facial bleeding or on chest bleeding or belly bleeding, but extremity bleeding, you've always got to bail out with a tourniquet.
You want to talk about compartments?
Well, we're just going through, how many compartments are there in the lower leg? 4 compartments, and you really should know all those muscles, right? What are the muscles in the anterior compartment? Okay, so he's got the first 3, so the big, the ankle extensor, the tibialis anterior, big toe extensors, and the toe extensors, so those 3, and then what's in the lateral compartment? Perineal longus and brevis. And what's in the posterior superficial compartment? Gastroc soleus, and then what's deep to that? And the flexors of the big toe and the flexors of the toes. That's it. It sounds like a lot, but it's really basically, that's it. There's just a few, parachute wires that are pulling these toes up and down, and that's it. So if you're going to do a compartment syndrome, which of those compartments is the most likely to present after revascularization with pain? You have 4 choices. Anterior by far. Anterior by far. And it's a little bit smaller, and I don't know why it's more vulnerable, but it is. And it's quite useful when you're examining that patient that you took for an acute limb ischemia. We will invariably test that anterior compartment. You'll feel the posterior compartment as well, but the anterior is the one that's going to get you. So you kind of feel it, and you have a calibration in your own mind of sort of how tight that is. You're comparing it to the other leg. Then you reperfuse it. You come by later, you're able to feel the calf. You can feel that anterior compartment. If there's any significant tightness and they're complaining of pain with tenderness, what other finding on physical exam is useful to demonstrate an anterior compartment syndrome? Change in sensation, and where is it? So right between the big toe and the second toe, anesthesia or change in sensation at the base of the big toe is a classic sign for your perineal nerve, superficial perineal nerve, deep perineal nerve, right, come down the lateral compartment, that if your deep perineal nerve coming out here in between your big toes is compressed, you're going to have change in that sensation there between those toes. That's an early sign. If you have that, you're definitely going to do a fasciotomy. And more or less, if you have a suspicion it's a compartment syndrome, it's much better to have a sort of false negative compartment exploration than it is to let somebody wind up with foot drop in an anterior compartment that shells out. If you kill the whole anterior compartment, it's just not a very good, you can have a limb, but it's not a very good limb. It's, sometimes it's not as good as fiberglass. So early assessment of sensation and movement in the big toe is worth doing.
So this is one of the things you can do upstairs. You can kind of fake it, because I know some of you have got a infrapopliteal exposure, but you can extend that incision. You can take down the superficial and deep posterior compartment, and then you can make an incision in the anterior compartment. We'll show you how to get to the perineal compartment.
We don't do very much using these devices that the ortho guys use. And I think it's partly because our threshold for intervention is just lower. We're talking about people with vascular disease, you're talking about limb-threatening issues. We just don't trust these pressures. They're hard to do consistently, and if you've used these various devices, they're hard to use. And if you have a suspicion, I think most of us basically work on clinical grounds, mostly for fasciotomies.
Yeah. So the inset bottom left shows a bad compartment syndrome. If you patient's got a true compartment syndrome, the whole muscle kind of bulges up and it's swollen. That's what you want it to do. And you're going to leave that thing open and change the dressing space every couple of days, reevaluate, see whether the foot basically is salvageable. And then gradually get the swelling down. You can partly reclose this, and then you typically put a wound vac or something on the remainder of the wound and let it close up with time. If you look on the right, that's a dead compartment. And so recognizing a dead compartment is, number one, the color. Obviously on the left, nice and beefy red. On the right, it's kind of this pale color. We usually take bovie and stimulate it with the bovie. Often it doesn't contract. You know you're probably going to lose the leg. Most of the time you have any dead compartment, the patient's probably better off with an amputation than trying to salvage that leg. All right. So, Linda, I did kind of the emergency thing. So you're off the hook. Is that all right? That you really want to start. Pardon? Whatever. That's the right answer. Toe amputations. You want to talk about toe amputations, John? I thought I'd pulled it up here. I got to find it.
You know, it'll be interesting for some of you, some of your programs, we were talking about it a little bit the other day, you will do a substantial amount of podiatry as a vascular surgeon. Some of your programs will farm this out to podiatrists and orthopedists. If you're at Baylor, for instance, with Joe Mills, you're going to do a lot of podiatry. How do you guys do podiatry, do foot surgery here? Not too much.
Don't even ask me. This is the hot topic of the moment, and you know, if you ask our interns how they do a toe amputation, they have no idea because we give them all away.
Right.
But we're going to change that. Don't worry about it.
Yeah, it's actually, I did a lot of foot surgery. The guys we worked with in Little Rock did all their foot surgery, and the guys in Greenville, South Carolina did their foot surgery. And it's quite variable program to program. Some of you, our fellows, they have no clue how to do foot surgery. And it's a very valuable skill. It's tedious, and you kind of have to, you know, pay a little attention. There are a bunch of bones in the foot, and they all have names, and you kind of have to look at it and, you know, spend some time. It's worth doing because not all podiatrists are equal. And you go do a long 6-hour sweaty femtib bypass using arm vein, and you're sweating blood over this thing, your back is sore, your neck is messed up, you're getting a cervical fusion afterwards, and the podiatrist comes in and does a bad transmetatarsal amputation and puts in an ischemic running suture with horizontal matrices, and the whole thing dies. And next thing you know, you're doing a BKA or an AKA because you did a tibial bypass, and when you do a BKA, you cut off your graft. It's very disheartening. So having input into what is appropriate for foot surgery after revascularization is pretty important. Toe amputation, for the most part, we use, I don't know if this shows it or not, but this is not a bad technique. It's a little dark, but using those tourniquets, using the loops on the back end of lap sponges is a good way to kind of separate the toes and give yourself a little more room. We don't usually take off normal toes like this one, but sometimes you have to. Typically, you talk about doing a racket incision, meaning it looks like a tennis racket. I orient the handle of the tennis racket on the second, third, and fourth toe along the dorsum of the foot. On the first toe and the fifth toe, I typically orient the handle of the racket on the lateral and medial sides of the foot. People do it differently. Your attendings will all have an opinion about how to do this. I find I kind of find that when I close the incision over the toe amputation, I'm closing essentially a vertical incision. I find that closes the gap between the toes better than if I've done it as a sort of a horizontal closure. But again, this is fielder's choice kind of stuff. That's why you're doing a 5-year residency.
So this patient's got a big ulcerated callus on the inside of the toe. So again, it depends what level you want to take your toe off. This is really going to be a transphalangeal, proximal phalangeal amputation that's going to actually take place here. And this is, you essentially make an incision around it and debride back the phalanx and then close the skin over it.
How many bones are in the toes? It's obviously a trick question. How many bones in the second toe? How many bones in your index finger? There's 3. There's 3 in the toes. How many in the big toe? How many in the thumb? There's 2. You've only got 2 in the big toe and 3 in the others. So you can have a distal and a proximal interphalangeal joint on the toes, and in the big toe you've only got 1 interphalangeal joint. One of the things to kind of remember is that the proximal phalanx sits on the top of the metatarsal like a cup on top of a mushroom. And by that, that's the metatarsal. The proximal phalanx kind of sits like that on it. So when you're doing a toe amp and you're trying to get your 15 blade into that junction, it's important to remember there's kind of a lip that runs around the metatarsal head that you have to get into. If you don't visualize that sort of mushroom cap on top of a round ball, you'll be banging into bone and you'll be proximal actually to the joint. You won't have sort of popped into the joint. The key is once you pop into the joint, then you can sort of work from inside the joint out, because part of what you're trying not to do is damage the soft tissue, the blood supply to the skin around the bone. You'd like to be saving enough skin so you have a sufficient amount of skin to close without tension. The most common failure I see, for instance, on a big toe amputation where you're not taking the metatarsal head is not saving enough skin so that even though you get the phalanx off, you get the big toe off, you don't have any skin to cover the metatarsal head, and then you have to take the metatarsal head, which you call a ray amputation. A first ray amputation is much more deforming than taking the big toe off and saving the metatarsal heads. If you lose the 5th metatarsal head or the 4th metatarsal head in a toe amputation, that doesn't have a lot of negative impact on the stability of the foot. But when you take the first metatarsal head, and certainly if you take the first and second,
is grabbing the tendon. And you pull the tendons down and then cut them, and then they'll retract back. You don't want the tendons sticking out of the end. That's what you're looking at here.
It's a little hard to see it. It's pretty dark on the big screen. But if you take a first metatarsal head, and certainly if you take a 1 and a 2, that creates a very unstable foot, because the way you walk is you hit your heel, you roll up the side of your foot, then you roll across the metatarsal heads, and then you lift off your big toe. That's how you jump, basically, is off the big toe. If you lose the first metatarsal head, you lose a lot of that stability on the inside of the foot, and your risk for recurrent ulceration goes up very dramatically. Whereas if you can just do a major toe amp and save the metatarsal head and have sufficient skin to cover that, you have a foot that's very likely not to get recurrent ulceration if you get into proper footwear and then do appropriate diabetic surveillance to make sure you don't get little ulcers and other things that would jeopardize your foot.
All right, oops, what did I do? It's not what I meant to do. So that's a ray amputation.
Ray means the metatarsal head goes, Okay, if you take and it can be the entire metatarsal or just the metatarsal head and toe. We call it a ray amp.
Yeah, sorry, this is not a ray amputation. That's
So
what
this
it should
would
have
be
said.
a
This is
toe amp.
toe amputation. Ray amputation's coming up. And then you close it with typically a vertical mattress, interrupted nylon. Same idea, a little bit easier to see. So often you put a ring block in. If you can do this with the patient awake, the digital nerves run on either side of the toe. So typically you basically go at one point and you go underneath the toe and then up the left side, go diagonally opposite, and you can block both sides of the toe and you'll get complete anesthesia from that. You want to make sure when you use the knife that you angle away from the adjacent toes. What you don't want to do is take off one problematic toe and make another problematic toe. So if this is the toe that's coming up, you're angling the knife into it, you're really putting it right on the bone and going all the way around, down to the bone. And then you basically take a bone cutter, cut the bone off, you're looking at the end of it, you dry it up, you pull out the tendons, and you cut them off so they retract way back. That's really when infection tracks up into the foot along those tendon sheaths. And then you take something like a bone bite or a duckbill, and you bite the bone back to the point that you got enough soft tissue coverage to take care of it. So we got permission for you to do toe amputations. Beck, I'll tell you whether you got to put them back on or not. We have permission on only 2 cadavers to do a BKA. If we've got time, we can demonstrate that for you, because these are the kind of things that you will get involved in fairly early. Angling the knife in.
The other thing that we'll be cautioning you about is the same thing as you take your knife to go around the umbilicus on a belly incision, is to keep the knife 90 degrees to the skin. The tendency on toe amputations is to kind of skive meaning you're taking a diagonal cut through the skin. Skin likes to be cut perpendicular. You know, it likes to have clean cuts. If you do the skiving thing, the problem is the edge of the skive is thin, so it's more likely to die back. So just keep the knife. It's hard to do it though, because as you're making a circle, you have to really work your hand to keep the blade 90 degrees to the skin. But it's important to do it. It makes a cleaner amputation. You know, we said yesterday, vascular surgeons live off of mice, not caribou, and this is one of the kind of mice procedures that, you know, you're going to see way more diabetic feet in your practice than you're going to see thoracoabdominal aneurysms. And you're probably going to have a lot more positive impact on people's lives by having effective foot surgery after revascularization than doing thoracoabdominal aneurysms, just by numbers-wise. This is where your practice is revascularization of the leg, limb salvage. It's a critical part of what we do. You can't be a vascular surgeon without being a, quote, limb salvage. I don't know what a limb salvage program is exactly. All of what we do is limb salvage. Every one of you will be a limb salvage surgeon because it's fundamental to the practice of vascular surgery.
Okay, this is a ray, a little more complex.
So you can see that the handle of the racket is oriented longitudinally along the metatarsal, and you can extend that as much as you need to. The length of the handle doesn't have much to do with the danger. There's no harm in having a longer handle because it's going to close easily. And so it really is a teardrop shape. And again, try to keep the blade perpendicular to the skin. You see how he's rotating the blade to do that. I usually do these with a tourniquet, like an S-mark. You can do it with an S-mark tourniquet that you know what S-mark is, just latex gauze, latex wrap, the stretchy stuff. You can wrap it up around the foot, bring it up around the ankle, and then tie it to itself. Instead of using a pneumatic tourniquet, you've created a tourniquet. It's kind of the Civil War style tourniquet, but it's pretty effective. And then you can do your toe amp, let the tourniquet down, so you've had no bleeding during the actual procedure. It's a pretty safe kind of a tourniquet, easy to do. And again, here, essentially you're trying to get down to the metatarsal phalangeal joint. And you can see it's a fairly definitive, you don't have to be friendly here. This is a definitive cut to get these things done. They've chosen here using a 10 blade. You probably find using a 15 blade is easier here. It's just a little bit smaller, a little more maneuverable. Yeah, I mean, some people like to do that. It is true that moving the toe back and forth, because And actually, the metatarsophalangeal joint is a lot more proximal on the foot than it appears topographically. And so moving the joint helps you to identify where that junction is.
So that's probably the metatarsal head right there that we're going to debride out.
Yeah. And you can, people do this different ways. Again, some people use little fine oscillating saws to come through the metatarsal bone, and you take the toe and the ray as one piece. Other people will do it like this, disarticulate the tarsometatarsal joint, metatarsophalangeal joint, and then rongure the head of the metatarsal away. That's, again, this is what's the problem, how to effectively remove a toe and get a wound to heal. How you do it, that's what 5 years is about. All of you are going to get different training of how to do that.
So you can do a variety of these things upstairs. Probably should pass them. This is not something you're going to do. This is actually a fairly complicated amputation to perform. Sartorius muscle flap. Let's just talk about that because you got it half exposed. Plastic surgeons are the anatomists of the 21st century. They actually know something about anatomy. Sartorius, the wandering sailor. It flexes your hip and externally rotates your knee and flexes your knee all at the same time. And runs from the anterior superior iliac spines inserted into the anteromedial side of the tibia along with sartorius gracilis semitendinosus. And it's got segmental blood supply, so it comes in at different levels. And it's easily the most common muscle flap that we rotate. We don't get plastic surgery to do, hey, you get paid more for putting a sartorius muscle flap in for doing the aortobifem. So you might as well learn how to do it. And essentially, I think in this case, the head bases the bottom of the field is not a very good, let's start off from scratch. Typically, the groin is open. And so you're going from medial to lateral. And what you're looking for these muscle fibers. The muscle fibers run vertically, actually somewhat inferomedially towards the right side. And what you're going to do is identify the muscle, take your Bowie, elevate the fascia from the front of the muscle to reach the lateral side of the muscle, and then you're going to go underneath the muscle. I typically put a Penrose around it sometimes, or stick a Army Navy underneath it to elevate it, and then you track up both sides of the muscle to the anterior superior iliac spine. And you disconnect it using electrocautery from the anterior superior iliac spine. So you will mobilize a length of sartorius probably about 4 or 5 inches, and that's enough to let you rotate that over and cover the femoral vessels. So it's one of those things you can also try since you're most exposure.
Yeah, there's actually been anatomic studies looking at the average distance from the anterior spine to the first arterial perforator is about 6 centimeters. The farther you mobilize circumferentially, distally, the more likely you'll have an ischemic sartorius. So one of the things we really do a lot is kind of leave the back of the muscle attached and really rotating it transversely rather than fully circumferentially mobilizing it, because you'll devascularize the whole shooting match. And the part of that muscle that you really need is the part that's up by the anterior spine, because where these infections, the reason you're moving it over is to get to the inguinal ligament. If you only covered down at the profunda, you've left that common femoral exposed. So it's an important thing to look at and how to rotate this over. The other thing to look for is where's the femoral nerve? It's right in there, essentially under the sartorius, and you kind of need to know where it is. It's a great opportunity today to look for that, because you'll never see it again until you have to do a sartorius flap. And then you're going to say, wow, I don't see that when I'm in the groin usually. This is the time to look for it.
So this is called distraction. We're distracting Dr. Well, we're actually putting the clips on the perforators because we rotate the thing completely over. I've never seen a dead sartorius muscle.
Every single one of these I've ever re-opt that's fully circumferentially mobilized is dead.
Yeah, no, never happens. 3 kinds of lies in medicine: lies, big damn lies, clinical impressions.
Statistical lies, yeah.
All right. So Jason, come on up here. You want to address the assembled masses before we go upstairs?
Thanks. Grab one of those. It's right under the thing right up there. Hey, first of all, thanks to Dr. Ite for coming and taking some time to go fishing. To teach you guys a little bit. Thanks to Dr. Lumsden for including us. How many years have we done this now? We've done it 8 years or something, 7 or 8 years. You guys are like, there were 37 attendees, and then from what I understand, there were 50 on the waiting list. So congratulations for getting in early and being a part of this. These guys are like the best, aren't they? Let's give them a round of applause because they are. I told them, I said, I don't know when you plan on retiring. I hope you don't do it anytime soon. But when you do, they should buy a big Prevo motorhome and put something like Vascular Learning Center on it and drive around the country to do stuff like this because it's like they're just great educators, and I love working with them, and they've been a great influence in my life professionally and personally, and so I appreciate those guys. Gore is super happy to be a part of this. This is my favorite meeting because we get to see you guys first, and it's a pleasure to meet you guys and be a part of it. And funny enough, I get to see you guys grow up, whether you know it or not. I'll see you at meetings, and I'll be the guy in a crazy paisley jacket smoking a cigar out by the bar somewhere, so you'll recognize me one way or the other. And then I get the joy of having Dylan and Jen stay around and being really close with those guys, and really looking forward to that. What I didn't do a very good job of is what I've always accused myself of being, a bad salesperson. I kind of just represented Gore this week and just myself, but we do actually sell some things like stents and vascular grafts. But you will get enough of that education when you get to your spot. So when you get home, it'll be a couple of weeks. I'm going to send you guys an email, and if you will send me your address of your physical address, I'm going to send you a letter, some business cards of your local rep, and then just some literature that's basically like brochures bragging on how great our stuff is. But it really is pretty good stuff. So I'll send you that stuff. I'm still working on we have a vascular combat manual. I'm hoping to be able to send one to each of you. If not, Gore Associates earn the right to say no, but we like to say yes a lot. So if you ever need anything, please ask your local Gore Associate. If you need a textbook or Rutherford or something like that, they reserve the right to say no, but if they like to say yes, so they usually can help you with stuff like that. So we appreciate you being a part of this. We appreciate being a part of this, so thank you guys for letting us do it. One thing we did, so we took a picture yesterday, and I went and we had it framed these are crappy frames, I'm telling you right now. But you know what? It's nicer than the one you would have bought because you wouldn't have bought one. So, fair? Is that fair? That's probably fair. So we have there's some white ones, white frames, black frames. There's a couple of gold ones. So I forgot to order them because the COVID thing got me, and I totally forgot to order them ahead of time. So I went to Hobby Lobby yesterday and bought literally the last 37 8.5 by 11 frames that they had. And I was walking through with a grocery cart, walking through there, and they were looking at me like, "What are you doing?" So I'm sorry that they're not all one color, but you can kind of pick your favorite color. If you don't like it, then they make markers and paints that you can cover it up. So again, thank you guys so much. I'm still going to be around. I'll be upstairs with you. I just wanted to thank you guys for being here, and thanks for kind of including me in y'all's fun, because y'all hadn't seen each other in person, and I'm not kidding you. Y'all acted like y'all knew each other for life. I mean, it was so fun. John and I were talking about this last night. Y'all really had a great time together, and y'all are here to, y'all are going to graduate together and move on together and see each other at meetings, so keep having fun together. It's a lot of fun, all right? Thank y'all.
Okay, Doc. Well, thank you, Jason, and thank you to the entire Mighty and DeBakey education team and the AV team. You guys have done a tremendous job, and thank you really for participating in this. We're always interested in feedback. Let us know. It's not totally comprehensive. There's lots of things. For example, we haven't even shown you how to sew an anastomosis yet. Maybe that's one of the things we'll show you when we get upstairs. But there's lots of things that are going to come your way. If there are things that you think we should put in this program, then let us know. And if we can accommodate it, we certainly will. We are flexible, and Becca has got some Fogarty catheters upstairs for you and got some torque devices, so you can actually play with this today. Mariana?
Yes, I just got a couple of announcements. I received a few questions this morning about reimbursement. So guys, today you're going to get the final link for the event survey. Make sure you fill that out because it will help us to process everything a lot faster. All of your receipts that you've saved, please email us. Let us give us about 2 weeks to process things, but you can email your travel-related expenses, your receipts to us. We'll process that. Fill out the survey, and of course, at the end of the lab today, just come back downstairs. We'll have lunch to go, and you'll be able to grab your luggage. So any other questions, just come by and see me. I'm glad to help out. Thank you.
I can't emphasize how, what a fantastic job you do in organizing this thing, the time you take, the details, you're running around constantly. You know, it's so seamless that it's easy to overlook. Just ordering all this food and getting people to and from the hotels and getting you upstairs and all the people that you put together to do this. There's no educational program that you're going to participate in anywhere that has a team like this that does it. We want to personally thank you for the job you do. I mean, it really is remarkable.
Thanks.
So last two people, Jason, thank you. Couldn't be done without Gore and Jason's support. Thanks to the other vendors too, but you're great. And to Dr. Wright, I think he's the best educator in vascular surgery, and we've kind of proven that over the last couple of days. So thanks again, John, for participating.
Thank you.
Best of luck.
Yeah, appreciate it.